Today we're going to go over med administration. So we're going to take a look at the meds that at EMT level we're able to administer or assist with. The in-depth review of these medications will be done in our lecture, but this way here you can see the medications, we can see the packaging, and kind of understand what it is that we're talking about. So if we start and we look at our aspirin, right? Before we do anything with medications, we want to make sure that we assess our patient. We've determined that there's a need for this medication, right? The indications are there, that we've assured that there aren't any contraindications, and that we've checked our 5 rights. So we have the right patient, we have the right medication, the right dose, we're going to administer it the correct route, it's going to be done at the correct time, and then the patient has the right to refuse, and we're going to correctly document that. So if I have the patient sitting in front of me, I want to make sure that we're checking things. So baby aspirin, all that really means is that it's chewable. So when we give these, and it can come packaged differently, you'll carry a bottle of this on your ambulance. This is a medication that we administer, so we carry it on the ambulance. So it comes in tablet form, and all the baby means is that it's chewable. So when we give this, our dose is going to be, if we have baby aspirin, they come 81 milligrams per tab. So when we give these, we would give somebody 4 baby aspirin. Okay, so that would be 324 milligrams. If you have the adult aspirin, then that would be 1 non-terracoated aspirin, and that's going to be 325 milligrams. So 324 to 325 is going to be our dosing range based on what type of aspirin you carry. So you're going to give this to someone, this orange flavored, you're going to have them chew it up. You want to make sure that they chew it, that way it gets absorbed quickly by the mucosa lining of the mouth, and it's going to get into the bloodstream quickly. If you have them swallow it, now it's got to go through that first pass metabolism through the liver. It's going to take about 45 minutes to an hour for that to get into circulation. So when we give this medication, somebody's having chest pain, and we know that they're having some type of cardiac event. We're going to make sure that they don't have any contraindications, so they don't have any active bleeds. There's no trauma associated with this, where there could be internal bleeding, that they don't have an allergy to it. Okay, so the aspirin, pretty standard. It's over the counter. Most people are familiar with it, and that's going to be something that we carry on the ambulance. If they have a prescription for it, they're having a cardiac event, they're having either an MI, or they're having maybe angina, so they're having some chest pain. If they have a prescription for nitroglycerin, then that's a medication we're going to assist with. Our dosing is going to be 0.4 milligrams. It comes either in the tabs or in the spray. The tabs, it comes in this amber bottle because it needs to be protected from light. So it's very sensitive to light, it's sensitive to heat, steam, so you don't want people keeping this in the bathroom. Once it's opened, it's going to be potent for 30 days. After that, when we administer this, the tabs go under the tongue. So they get 1 tab, and they're very, very small. Okay, this is live nitro, so I'm not going to touch it, but we can see there, okay, they're very, very small tabs. We're going to give that to somebody, it's going to go under their tongue, it's going to dissolve. So again, it's going to get into that mucosal lining quickly. This is a vasodilator. So we want to make sure that we don't have any contraindications for this. Contraindications is going to be that their systolic blood pressure, for testing purposes, is less than 100. Okay, Massachusetts is going to be less than 120. All right, so they need to have a blood pressure of 120 or greater in Massachusetts. Nationally, it's going to be greater than 100. All right, the other contraindication is going to be our phosphodiesterase 5 inhibitors, so that's going to be something like a Viagra or Cialis. So if they've taken that in the last 72 hours, we need to withhold this. That would be a contraindication. All right. Patient would have to be prescribed this. They'd have their own. If they have the spray, then the spray is a lingual spray. So the tab, sublingual, under the tongue. Spray, lingual. You can spray it right on the tongue. Okay. You'll hear people say sublingual. It may be written in your book as sublingual, but when you read the labeling on the manufacturer's container, it tells you that it's a lingual spray. Okay, so the dosing's the same. Anytime that we have something like this, you need to prime it. So before we would administer this to the patient, after we've checked our 5 rights, made sure there's no contraindications, when we prime this, we point it away from anybody, because again, this is live nitro. It's a vasodilator. If you point it at somebody, it's going to get absorbed, and it's going to cause them to have side effects. You're going to prime it by pushing, making sure that when we go to administer this to our patient, they're going to get a full dose. If we don't prime it, they may, when we squeeze it, they may only get half a dose. So that's what we mean by priming. Okay, we're going to give it a full spray, so that way the pump is primed, ready to go. So when we spray it for our patient, they're going to get one dose. If you were to not prime it and you spray it and you only get half a dose, and then you give them another dose because you're like, well, that wasn't a full dose, now we've overdosed the patient. Okay, so we don't want to do that. This is something that we can repeat every 5 minutes up to 3 times, so a total of 3 doses. So we have our initial dose, we can repeat it after 5 minutes, and then again after 5 minutes for a total of 3, as long as their systolic blood pressure maintains at least 100. If it were to drop under that, then this would be contraindicated. Okay, so those are our medications for our patients when they're having a cardiac event. Aspirin, we carry. Nitro, we assist with. If we have a patient who has asthma, COPD, and they are prescribed a metered dose inhaler, this is a very typical metered dose inhaler. All right, it generally comes packaged in a box, and that's where the prescription is going to be. So in terms of knowing what the correct dosage is going to be for this is going to be dependent upon how they're prescribed it by their doctor. So it has this little cap here that should stay on, and that's going to protect it. So people carry this in their pocket. That way, pocket lint and all doesn't get in there. All right. This is an inhalant. So it's a powder that gets aerosolized. So when they take it in, we're going to kind of talk them through how to do this correctly. A lot of times you're going to watch people take their inhaler and they're not going to self-administer it correctly. Ideally, they'd have a spacer. So they'd have a device that this would go into, and they'd be able to take a couple deep breaths to be able to get more exposure to the medication. So this is a little canister. This is going to have all the information on it, so the expiration date. You want to make sure if we're going to assist somebody with this medication, so they have this, they haven't already taken it, then we'll kind of go fetch it for them, and then we want to make sure that this belongs to the patient. Okay, so again, you go 3 or 5 rights, make sure that this belongs to the patient, find out why they're prescribed it. Are they asthmatic? Do they have COPD? And then, this is the right time. So you hear wheezing, inspiratory or expiratory, or inspiratory and expiratory. This would be the proper time to administer this. You should have your patient on oxygen. And then, same as when we go to do this, when we coach them through it, what we want to do is make sure that we prime it, same as we did with our nitro. So you want to get that full spray out. So if somebody doesn't have this cap on, even if they do, if you've got foreign matter in there, pocket lint, any type of particles, we don't want to shoot that down into their alveoli. That would be very, very bad. Don't do that. So when we have this here, you're going to prime it. Then what you're going to do is you're going to coach them. You have the oxygen on, have them take some nice, slow, deep breaths. Okay? Then you're going to demonstrate for them first, and then have them follow. So you're going to say, I want you to take in a nice deep breath, and then an exaggerated exhale. Breathe everything out. Then on that next inhalation, we're going to assist them with taking the inhaler. So it doesn't go into the mouth like you normally see. It goes in front of the mouth. So now, after they've had that exaggerated exhale, on the next inhalation, that's where we're going to squeeze the canister. They're going to take a nice deep breath, and we want them to hold it at least 10 seconds. This can be very challenging for someone that's in an episodic asthmatic attack. So they're already struggling to breathe. We want them to try to hold their breath as long as possible, because as long as they're holding it in their lungs, they're getting exposure to the medicine. So talk them through it. Hold their breath. You're doing great. 1 1,000, 2 1,000, 3 1,000. Keep going. You're doing great. You're almost there. 5 1,000, 6 1,000. Excellent. Keep going. Hold it a little bit longer, a little bit longer. Now we're at 10. Now they have that exhalation. Okay? Oxygen goes back on. Let them take some nice, slow, deep breaths. Catch their breath after holding it. Then do that second puff administration. Okay, so this is going to be dependent upon how it is prescribed to the individual. But this is a metered dose inhaler. It's metered dose because every time you spray it, they get the exact dosage of medication. So just make sure that we prime that ahead of time. You want to coach your patient through it and make sure that they take it. Even if they self-administer it, a lot of times, you see people, well, that's not helping them get exposure to the medication. So a lot of times, even if they've already administered this, they may not have done so correctly. So again, contraindications, if they've already administered it, they've reached their max dosing, then we're not going to be able to assist them with this. If you work for an agency where you're able to do nebulizers, so this is albuterol, okay? So this package tells you right on it what it is, 1.25 milligrams in 3 milliliters of saline, and it comes in this bullet. So you'd open this up, you'd put it into your nebulizer, and you'd attach your oxygen to it, and then it gets aerosolized. So this would run with a face mask or a T-bar, and they'd be able to get more exposure to the medication. So this is going to be something that's going to be dependent if your agency allows you to do that. When we move on to our diabetic patients, so if we have a patient who's hypoglycemic, and we're looking to administer oral glucose. So for this, they need to have a blood glucose level. For testing purposes, they kind of split the difference. So it's between 60 and 80 is going to be your range for someone who's hypoglycemic. For testing, they pick 70, they split it right down the middle. So 70 milligrams per deciliter of blood, that when we checked their blood glucose level, if they were 70 or below, and they were symptomatic. So symptomatic, they're slightly altered, they're confused, maybe they're slurring their words, they're kind of unsteady on their feet, they're dizzy, they're nauseous, something where they're symptomatic with their symptoms. Then it would be okay to give this. Contraindications, your patient has to be alert and conscious. They have to be able to follow directions. So if they have the inability to follow directions, we couldn't give them something to put in their mouth. If they can't swallow, they have difficulty swallowing, then this would be contraindicated. We couldn't give this to them. Okay, so our max dose of glucose is going to be 25 grams. So this is grams, not milligrams. It comes packaged differently, and depending, what type of package and how it comes. So you may see that this comes as 15. So usually we give somebody 2 tubes, so we might be a little bit over. So you give them 1 tube at a time. You're generally going to start kind of half a tube, right? Give them a little bit of sugar, see how they do. So we don't need to give them the whole thing all at once. Okay, so this is lemon flavor, very tart. It's kind of like the icing if you go to like Stop and Shop or supermarket somewhere and you buy the icing that you write on the cake and then it's never legible, right? But it's super sugary. That's what this is. It's pure sugar gel. All right. So it's going to go on to the best way to do this. The route of administration is buccal. So it goes on to a tongue depressor. So squeeze, a little bit, put it between the cheek and the gum. That's buccal. B-U-C-C-A-L. It goes in between the cheek and the gum, and it gets absorbed into the mucosal lining. So the sugar gets into the bloodstream very quickly. Then reassess. So you want to reassess that blood sugar. So if you give them a whole tube, they may not need a whole tube. Okay. You want to make sure that your patient remains conscious, that they don't start to lose consciousness on you. Make sure that they don't have secretions. This is very tart. It's going to cause them to salivate. Make sure that they don't have secretions that they can't handle. All right, so give them a little bit at a time, see how they handle it, reassess their blood glucose before you would re-administer. All right, so it comes in different flavors. All of them are just very, very tart, very sugary. Okay, so that's our glucose. Again, hypoglycemic, they have to be symptomatic. Testing, 70 milligrams per deciliter would be the cutoff. You have to have a glucometer. If you don't have a glucometer, then you are not allowed to administer glucose. This is something we carry on the ambulance. Okay, so this is something that we have and we administer. So next, we've got our medications out for somebody with anaphylaxis shock. So somebody that has, for nationally, this is something that testing, it's a medication we assist with. The patient should have their own prescription. In Massachusetts, when you take your psychomotor exam here, this is something, Massachusetts, we carry on the ambulance. So these here are trainers, so I'm going to show you how to administer. These do not have any medication in them. These are the live EpiPens. So they come packaged slightly different, okay? So this is one type. So this is our adult EpiPen, okay? We can see that it's yellow. The needles are always going to be orange and the cap blue. This here is our PD. So we see that our PD, and it comes in this container. So again, cap's blue, needles orange, but the PD is going to be our junior, EpiPen Junior. This is green. So they come slightly different colors. This here is its own little sharps container. So after you administer it, you have a sharp. This is a needle. So it can go right back into its own sharps container for proper disposal into a sharps container. These ones here, these are just different packaging. It's the same thing. So our adult is yellow. This one, the PD, is our junior is orange. So same thing. Our adult's always going to be 0.3 milligrams. And our PD is always going to be 0.15 milligrams of epinephrine. Epinephrine, we give it for its vasoconstricting properties. So if somebody's having anaphylactic shock, we want it to clamp down on the vasculature, right? Stop the permeability, so we can stop that edema. So this is going to be what makes it anaphylaxis versus a hypersensitivity and allergic reaction is going to be that airway compromise. You hear stridor, you see angioedema, so they have swelling to the eyes, to the face, to the lips, to the tongue. You start to kind of hear that stridor. They're making that clicking sound with their tongue. That means that we've got airway compromise, and we want to act very quickly. Okay, so in terms of this, nationally is something that they carry. Nationally is something that they have their own prescription for. It would be something we'd assist with. They'd have to have their own EpiPen. For our purposes, this is going to be something that we carry in Massachusetts. We carry on the ambulance. So when we want to administer this, remember this is a needle. So you don't want to get in the habit of putting your thumb over the top to administer this. You always want to hold it like this, all right, out at the side. I've seen many a person put their thumb on the wrong end and quickly go to administer it, and now all of a sudden you have this needle go through your thumb, and this is a potent vasoconstrictor. It's going to constrict the vasculature of the thumb, and if it isn't reversed, you can lose the thumb. It'll become necrotic, they'll have to amputate. So safety first when you administer this. Make sure, take your time. Do it correctly. Check your 5 rights. This would come out of its own little sharps container. You remove the cap. Now it's live, which means if you hit somebody with this, you're going to administer 0.3 milligrams of epinephrine to them. So when we're going to do this for our patient, you want to go in that lateral thigh. Okay, so make sure there's nothing in the pockets. There's keys, coins, phone, something that if we were to hit this, then it's going to bend the needle, they're not going to get a full dose. So you make sure that everything's cleaned out, you find that lateral thigh, right? You let them know what's going to happen. So you're holding it correctly, it gets at a 90-degree angle, you're going to come straight in, and once you administer it, you're going to hold it here for 10 seconds. Make sure that all of the medication gets exposed. This is an intramuscular route. It's going into the large muscles, the quadriceps. So after we've hit 10 seconds, 10 Mississippi, now this can come out. So this is now a needle. So this now needs to be disposed of properly in a sharps container. All right, so that's why they come in their own little sharps case. Otherwise, this needs to be put into a biohazard sharps container. The trainers, they're for multiple use. So it just slides back in and then you put the cap back on and now it's ready to go again for another go. We can repeat this up to 2 times because we carry 2 in the ambulance. So 5 minutes apart, 10 minutes, depending how symptomatic our patient is. Okay? So if there wasn't any change, we didn't see the positive outcome that we were looking for, they're not having less difficulty breathing, we still have that angioedema, then we'd re-administer, go to the other leg. Okay, don't go in the same spot. These here, the secondary effects of our epinephrine is going to be that bronchodilating. So this is going to work really well for someone with anaphylaxis. So when we listen, we may hear wheezing. Right, by the time that it's progressed to the airway, we're going to hit stridor, that upper airway occlusion, and that's when we know that we have minutes. We need to administer and get this epi on board. That's what's going to save them. Make sure that your patient gets oxygen. Treat them for shock. All right. So we want to make sure that we get them to the closest appropriate facility. So it comes packaged a little bit differently, and then the trainers just so that we can practice how to administer appropriately. So one of the things that nationally, our next medication that we'll look at is charcoal, activated charcoal. So this is going to be for our poisons and toxins. So this is something that we no longer carry on the ambulance in Massachusetts. So it's not really practical for us. As national, this is still a medication that at the BLS level, you have the ability to administer. So it is still a national med, it just is not something that's carried in Massachusetts anymore in the ambulance. Activated charcoal, it is an adsorbent, adsorbent. And what happens is, you mix this charcoal with water, you make a little slushy. Yum, nice little charcoal slushy. What doesn't sound better than that? Then you have to have them drink it. So first we have the complication of trying to mix this in the back of the ambulance and find something for them to drink out of. Then it tastes like charcoal because it's charcoal. So it doesn't taste that good, and this stains everything. Teeth, skin, clothing, back of the ambulance. Anything that it touches, it's going to stain. It is an adsorbent. So it's going to go down into the stomach, so we have an hour to work with. Once somebody's ingested something, then we're going to administer this charcoal. It's going to have it acts like a magnet. It has all the poison bind to it. So all the poison kind of clings to it, and now it passes through your body, so it prevents the poison from being absorbed, absorbed. So it doesn't get into the bloodstream. It's able to pass, and they pass it when they go to the bathroom, and you have this crazy black charcoal diarrhea for a very long time. It can be up to 2 days that you're passing this charcoal, but it prevents the poison from being absorbed into the body. Contraindications for this: we wouldn't use this for somebody who had taken in an acid or something that was caustic. If it burns going down, it's going to burn coming up. And if it's been more than an hour, then this really isn't realistic for us. It's already passed through the into the intestines, it's passed through the stomach, and this medication isn't going to be successful. All right. So this is something, again, we'll know for testing. It comes packaged slightly different, but it works the same way. Okay. And then the last medication that we're going to talk about is going to be our Narcan. So Narcan is a medication that we have a dosing range. So a dosing range for Narcan is going to be 0.4 to 4 milligrams. So 0.4 milligrams to 4 milligrams is our dosing range. And the caveat to that is it's titrated to respirations. So for us to administer Narcan, the indication is going to be that we have somebody with an opioid overdose. So Narcan only works as an opioid antagonist, only works on opioids. So if it's another drug in their system, this isn't going to work. So if we're going to administer this, they have an opioid overdose and they have respiratory depression, which means they're breathing, inadequate to sustain life. They're breathing less than 10. Generally, they're like 4 times a minute that they're breathing. Super inadequate. We need to ventilate them. Before we would ever consider administering this, you have to ventilate your patient. Okay? They're depressed. They're acidotic. Their brain is hypoxic. So if we would just push Narcan, we're waking up a hypoxic brain. That's very dangerous. We don't want to do that to our patient. Okay? Once you have your BVM, you've secured the airway with your OPA, and you're ventilating the patient, you're now controlling the ventilatory rate. The problem, the respiratory depression, we fixed it. This patient isn't in danger anymore of dying. We've now fixed the problem. The problem was they had respiratory depression. We're ventilating the patient on high flow oxygen with our BVM. Now we need a good 5-6 minutes of ventilating the patient appropriately for an adult patient, right? 1 breath every 6 seconds. Good tidal volume breaths, reverse the hypoxia. That way, when we administer this, we only want to give enough. That titrated to respirations means that we're only giving enough to get them to start spontaneously breathing again. We want them to start breathing 10, 12, 14 times a minute. Not necessarily wake them up. Okay? Waking up a patient before we reverse the hypoxia, now they're going to wake up combative, they're going to vomit, right? They're going to be angry, they're going to be confused. So we're waking up a hypoxic brain. Very, very dangerous, so don't do that. When we have our dosing range, when we look at these vials, they come packaged like this, okay? So this is when we draw it up, I'm going to show you how to do this. So when it comes packaged, we can see here, this is our naloxone hydrochloride. This is packaged 2 milligrams per 2 milliliters. So anytime that we're going to administer Narcan, we want to make sure that we have the correct concentration. We know what we're doing. We always document our medications in milligrams, or grams, micrograms, not milliliters. Milliliters is a fluid volume. So like our aspirin, when we administer that, we're giving 81 milligrams of aspirin in 1 tablet, but the whole tablet, right, the medication is secured in that tablet, and that's how it's being administered. For Narcan, when we administer this intranasally in each of the nares, we're going to administer it in volume. So the milliliters is how much volume contains that dose of medication. So 81 milligrams is contained in 1 tab. 2 milligrams per 2 milliliters. So if I push 1 milliliter, I'm giving them 1 milligram. And I know this can kind of get complicated, so we're going to go over this kind of quickly. So when we look at this, these come in different dosing. So when we compare these two, we have one that says that it is 1 milligram in 1 milliliter. Then this one here says 0.4 milligrams in 1 milliliter. So this is why that concentration is important, because if we were to look at this, if I said that I administered 1 milliliter of Narcan to my patient, that means something very different with both of these vials. And this is why we always use milligrams, because in one, I'm giving 1 milligram in 1 milliliter. Okay? In the second one, we're giving 0.4 milligrams in 1 milliliter. Other concentrations, we can have 4 milligrams in 1 milliliter. So if I were to say to someone, I gave them 1 milliliter of Narcan, well, the dose of medicine that they got is going to be different. Because if I just say 1 milliliter, well, what's the concentration? Because did I give them 1 milligram? Did I give them 0.4 milligrams? Did I give them 4 milligrams? So this is the dose of the medication. This is just the kind of the vehicle that gets it to the patient. Okay, so same as we would say 1 tab of a pill, like aspirin, we gave them 1 tab, 1 capsule. However, it's packaged. In fluid, when we give this is what we're talking about. So the milliliter, the volume of fluid, is not how we would ever say that we're administering this medication. We always want to use our doses, okay? So hopefully that kind of clarifies that a little bit. So when we look at this, if we're going to use our 2 milligrams, so we have our medication, so it comes with our Bristol jet and our medication. So this is our vial. This is a Bristol jet. At this end here, when we pop this off, we have a little needle. This is going to screw right in, okay, to this port. This here is going to be where we put our MAD, okay, so our medication administration device. So I'm going to show you, this gets easily secured into this, and we kind of draw it up. So when we have it all put together, medication screwed in, atomizer connects right here to our lure lock, and we want to make sure that this is on nice and square, is secure, everything's nice and tight. And then when we have our medication here, it's going to get zeroed out. So now I want to make sure before I give this medication that I zero it out, so I have my plunger right at my 0. When I administer this, you want to put the nose into a piggy position, and you're going to close off one nary, and you want to point the atomizer up and out. So not straight up, you want to go up and out at an angle, so that way we can hit the turbinates, so that way we can have more surface area for the medication to absorb. So when we push this, and when I push it slow, it dribbles out. Okay? And now we get drop, drop, drop. So you have to push this fast to be able to atomize it, to have that mist. Okay? So when you do this, you want to look at where it is that you're going to administer. Each nary can only absorb 1 milliliter of volume. So the total, I can only put 1 milliliter in each nary at a time. Then it needs time for that absorption to happen before we could re-administer. Okay? So if I were to go and push 2 milliliters up, most of it's going to drain out of the nose because it's not going to be able to absorb that much fluid. All right? So these devices here, depending where you work, I know in our area around here in Massachusetts, we have a heroin opioid epidemic. So this is a medication that you're going to become pretty familiar with. Again, depending where in the country that you work. So when we recognize somebody with an opioid overdose, pinpoint pupils, respiratory depression, paraphernalia around, first thing that you want to do, ventilate the patient, reverse the hypoxia. Narcan is titrated to respirations. Okay, so we only want them to start spontaneously breathing again. So this is kind of just a very general overview for us. We'll go over this more in depth in our lecture, but now you're kind of familiar with the medications, how to administer them. And again, this will be something that we'll go over in lab as well. So hopefully you found this educational, and we'll see you next time.